Hello, and thank you for the opportunity to present at today's conference. My name is Dr. Courtney Cronley, and as you can see from my title, I'm going to be talking today about an instrument called the VI SPDAT and potential racial and gender disparities or bias in that instrument. So just to give you a little policy context for the VI SPDAT in today's conversation. So the US-based Department of Housing and Urban Development, which is the primary federal entity that provides funding and support for homeless services, adopted a housing first model in the late 90s, under which they said that persons need to be placed in housing before we focus on mental health or substance abuse wellness. And this was and that once persons had stable housing, they would be best situated to be able to engage in the services needed for any sort of recovery or long-term stability. So this was quite a flip from traditional models of homeless services during the 80s and 90s, where the focus was largely on emergency shelter, and housing was really only granted to those individuals who had showed evidence of overcoming any sort of addiction or seeking or securing mental illness, mental health or physical health services. And the idea being that those who had the most wellness would then be the most likely to succeed in housing. So the housing first model sort of totally flipped that on its head. But within the context of housing first, HUD eventually adopted a coordinated entry system in which they required communities of service providers to work together to identify those individuals in their communities who were most in need of housing, and then to place those individuals in housing first. The idea being that if we have a limited supply of housing, then we prioritize those individuals who are most in need of housing and then work down the list. And they required, as part of this housing prioritization process, that service providers who were working within a single coordinated entry system would use a set of objective screening and assessment tools to measure, identify, and quantify housing need. So vulnerability assessments became sort of the best practices for triaging housing decisions within the context of coordinated entry. And over time, one tool in particular became most widely used in the United States and to some extent in Canada, and that is called the Vulnerability Index Service Prioritization Decision Assistance Tool, otherwise known as the VI SPDAT. So where does the VI SPDAT come from? Well, the VI SPDAT is actually an outgrowth of the SPDAT, and this SPDAT was originally developed, not entirely according to the original instrument authors, which was a consulting firm in Canada called OrgCode, in conjunction with a community organizing group in the States called Community Solutions. They developed the SPDAT drawing on research to some extent from a single study of street dwelling individuals in Boston, Massachusetts during a particularly cold winter. So during this particularly cold winter in the late 90s, there was a disproportionate number of individuals who were sleeping on the street, unsheltered, who were dying. And a set of team of researchers worked together to try and identify what were the indicators or predictors of mortality for this population, largely in hopes from a public health perspective of preventing these deaths in the future. Some of the problems with basing a more standardized, generalized assessment on this study, if you were only using the study's data, first of all, the sample was mostly white and male. There was a geographic bias towards mortality risks that were cold weather based, such as and male based, such as frostbite, hypertension. And then finally, the researchers, as they state, never intended to create an index of vulnerability or housing need. Instead, they were creating an index of mortality risk. Regardless, the VI SPDAT became the standard tool of practice across the US, as I mentioned. The VI-SPDAT is comprised of 4 subdomains and specific items on those subdomains, which are measured to some extent differently, sometimes yes or no, sometimes number of times, sometimes years. The VI-SPDAT data are collected through self-report to an interviewer. So when a person, and every community has a slightly different model, but in general, it's designed so that when a community member comes into a service provider, the service provider asks them the questions on the VI-SPDAT and records the answers. The consulting company that operates the system does offer an extensive training on use of the VI-SPDAT, or it did when the VI-SPDAT was still widely used. I'm sorry, so you can see the subdomains of the VI-SPDAT are history of homelessness and housing. So sleeping, where they sleep, how long they've been in permanent stable housing if they have, and times homeless in the last 3 years. Risks, so health risks mainly based on utilizing formal healthcare services and criminal justice services, as well as being attacked or threatened or engaging in any risky behavior. Socialization and daily functioning that has to do with interpersonal relationships and to some extent money issues in terms of owing people money or feeling like you have received money or have income coming in. And then wellness that has to do with your, largely to do with your health status, physical and mental, substance abuse, and then to a small extent, if you've had any experience of trauma, which is that last question, Q27. So as I mentioned, the VI-SPDAT, when it was first adopted, didn't necessarily go through the standard psychometric analysis of reliability and validity, which is considered the basic process for assuring a measurement tool's, shall we say, quality and trustworthiness. So reliability is a concept in psychometrics or measurement development that means the extent to which the scores on a measure are accurate and consistent. So when someone takes an assessment today, their score should be similar to the score that they would receive tomorrow or the next day or the next week if nothing really has changed in their life. Validity, the extent to which an assessment measures the construct or concept of interest, so in this case, vulnerability. Good example of validity slippage might be when you think about measures of depression and anxiety. To what extent does an instrument measure depression versus anxiety, right? So it's important to have a strong conceptual definition of the concept going in such that you can assess the degree to which it validly measures that construct. The problem with the VI-SPDAT is that there really was never a strong conceptual definition of vulnerability before the instrument was developed and then adopted. Now, there are also multiple issues that can affect reliability and validity. Who asks the questions? As we said, most community organizations using the VI-SPDAT based it on a service provider or a case manager asking clients who are presenting for services the questions on the VI-SPDAT. Questions where they are asked. So are they asked in the context of a service setting, or are they asked over the phone, or are they asked over the internet through an anonymous Qualtrics survey? People have different levels of response and comfort and honesty based on where the questions are being asked. Difficulty in wording of the questions. Have you framed the questions such that respondents can understand them and answer accurately based on an accurate understanding of what's being asked? And then of most interest to this study is cultural sensitivity. So to what extent do questions reflect different cultural, racial, ethnic, sexual, gender, orientation identities, and give a fair assessment of whatever the concept is across racial, ethnic, and other identities. So cultural issues are of particular concern for any assessment used in homelessness for a couple of reasons. First of all, about a third of persons experiencing homelessness in the States are female, which means that any instrument would need to be sensitive to both male and female experiences. Almost 40% of individuals who are homeless in the United States or who experience homelessness are African American or Black. This is wildly disproportionate to the overall US population, which suggests that any instrument needs to be very sensitive to the experiences of Black persons in carefully vetted from a African American Black experience before being widely adopted in the homeless services setting. And then finally, we know that Black, Indigenous persons of color, and women face multiplicative risks for trauma and poverty in wider society, which would suggest that any instrument, if it's going to be able to fairly assess vulnerability, however we want to define it, would need to be able to be sensitive to the potential extreme risk for trauma or poverty amongst Black women, and be able to characterize that effectively when capturing their vulnerability and need for housing. Overall, these issues are pointing to the importance of using an intersectional lens when assessing vulnerability within homelessness, and not thinking about it as a narrow, single-minded paradigm of vulnerability, but that vulnerability might differ based on persons' intersectional identities and positionalities. There's also been other research to a small degree on the VI-SPDAT, and it largely suggests that some of these intersectionality issues are not being addressed in the VI-SPDAT. So, for instance, one study found problems with reliability, and the authors postulated that it may be due to self-report and respondent-rater interactions. There was a study done in Texas with that showed pretty strong evidence of racial bias, particularly for Latinx populations. In addition, IPV providers have written white papers and briefs arguing that questions create discomfort for individuals who may be experiencing sexual trauma, and that they may not, or who have a history of it, and they may not feel comfortable answering honestly to certain questions, such that their vulnerabilities around sexual and trauma and trauma more broadly would be underaccounted for in the VI-SPDAT. All of this led to the current research questions for this study. First of all, I wanted to know if trauma overall was a reason for entering homelessness differed based on race and gender. Because as I mentioned, women are at higher risk for trauma in the larger population, so you would expect to see this also to be the case in the homeless population, but maybe not. Also, to what degree did trauma as a reason for entering homelessness predict VI-SPDAT scores? So was this a strong driver of vulnerability scores? I asked whether race and gender predicted VI-SPDAT scores, and whether or not race and gender interacted with trauma to predict VI-SPDAT scores, such that you might expect to see women who report trauma or Black women who report trauma scoring higher on the VI-SPDAT. And secondarily to all of these intersectional questions, I just wanted to know how individual items on the VI-SPDAT differed by race and gender. So the data for this study were collected as part of coordinated entry over a 2-year period in a single county in the United States, and those data were stored in an a homeless management information system, which is an electronic data management system. So each community provider that works within the coordinated entry system would utilize the VI-SPDAT when clients came into their agency seeking services, and they would record their responses in the HMIS. The setting is the 3rd largest county in the state in the southeast of the United States. The state county is disproportionately white, with only 9% residents reporting to be Black, and just under 4.5% reporting to be Latinx or Hispanic. Key variables that were used in this study: gender, male and female, and race, Black or African American and white. Gender and race were dichotomized due to very small numbers of persons responding to be any gender other than male or female, or any race other than Black, African American, or white. And then trauma, which was pulled from the VI-SPDAT and was the question that you can see before you. Has your current period of homelessness been caused by an experience of emotional, physical, psychological, sexual, other type of abuse, or by any other trauma that you have experienced? In order to answer the research questions, I first examined any assumptions of the variables related to normality and outliers, and addressed missing data The total sample was 1,025 cases, but on any single variable, we might have had up to 10 cases missing, and those cases were simply deleted through list-wise deletion. Bivariate, chi-square, and t-test were used to test for group differences in trauma, VI-SPDAT, total scores, subscales, and individual items. And then I utilized the process macro for SPSS to test the moderating analyses of race and gender, and race and gender and trauma. The first moderation model included trauma, gender, race, gender times race, trauma times gender, trauma times race, and age. Gender times race was non-significant, so I dropped it in the second model, which I considered the final model. So it included trauma, gender, race, trauma times gender, trauma times race, and age. So you can see at a bivariate level some of the interesting findings. Primarily within gender, women were reporting higher scores on the subdomains. When you looked at homelessness history, though, in terms of race, I think what was interesting was that whites were reporting higher scores on the subdomains, except for homelessness history, where blacks reported higher scores. And then if you looked at the bivariate differences across gender times race, you saw pretty consistently that white females were scoring the highest out of every single group. And the only exception to this was homelessness history. And additionally, when we looked at individual items, we found that women reported higher rates of formal healthcare utilization, such as emergency rooms, ambulances, and crisis services, but men reported higher rates of drug use and legal problems. White individuals compared to blacks also reported higher rates of emergency room, ambulance services, and inpatient services. So again, white persons were reporting higher use of formal healthcare services compared to black respondents. When we looked at the results of the moderation model, we see that the overall model explained about 25% of the variance, which is pretty good. And that trauma and race were really the key significant variables in the model. Based on the moderation model, when we looked at the VI-SPDAT total scores, white women were scoring the highest on the VI-SPDAT, followed by white men, black men, and then finally black women. And this final slide, or this slide here, shows just a visual of the differences in the VI-SPDAT scores, the estimated marginal means, controlling for homelessness due to trauma or abuse. And you can see that white females, who are the red error bar at the top on the right-hand side of the screen, are the highest. So what does all of this mean? Going back to the original title, does the VI-SPDAT potentially perpetuate gender and racial biases that we already know exist in homelessness? My analysis would say potentially yes, because if a community is using only the VI-SPDAT scores or primarily the VI-SPDAT scores to make housing decisions, the results would deprioritize Black individuals over their white counterparts. Knowing that Black individuals already face greater risk for housing discrimination and entry into homelessness, the VI-SPDAT creates just one more barrier for them to be getting housing. My study also kind of points back to this idea of what is even vulnerability anyways, because the racial and gender differences are suggesting that vulnerability is not working the way we would expect it to, and points to a need to think more deeply about how different positionalities in society and in the homeless population might reflect different experiences of vulnerability. So for instance, a lot of the questions relied on self-report of formal healthcare services, but we know that BIPOC individuals in the community overall report more distrust of medical institutions, in large part due to historical medical misuse by the medical system. And so relying on formal use of formal medical services as an indicator of vulnerability may be underrepresenting the vulnerability Likewise with women, when you have self-report of sexual and traumatic experiences, a woman may be less likely to be reporting those. And so particularly for a Black woman, this may be showing up in lower vulnerability scores. Now, understanding also, this study didn't even begin to look at vulnerabilities of groups like sexual and gender minorities. So that's a whole other area to look at and think about vulnerability. As I mentioned earlier, perhaps self-report is driving some of the differences that we're seeing in vulnerability scores. So thinking more about how we collect those data, and then thinking about how vulnerability scores are even corresponding to housing need, because that research really hasn't been done yet. We're not even sure if vulnerability reflects what we would consider housing need. And then potentially even asking whether or not data-driven approaches like vulnerability assessments are the best way to deal with housing shortages and homelessness, when the reality is we just have a structural system in which we don't have enough or an adequate supply of housing. Final issues: does a one-size-community model of housing assessment even work? Or should HUD be allowing, or even the Canadian government be allowing, more community-driven processes for identifying housing need? In the US, some communities are already adopting their own systems for housing assessment, and they're starting to introduce new aspects to vulnerability or housing need, reflecting the fact that our original conceptualization of vulnerability may not fully capture what it means to need housing. So on that note, I'd like to end. I thank you for your time, and I invite questions via email.